named so because of Bernasconi-Casanari, so it's also the artery of Bernasconi-Casanari, and that supplies the tent. If you think that's thought of as at the back of the head, and we're talking about anterior circulation, and you'll see that just how far-reaching the anterior circulation is. As you get into the dura, commonly the first branch that's described as the ophthalmic artery, and usually the superior hypophyseal artery either comes directly off of the internal carotid, but can also come off of the ophthalmic artery. You then go on to the communicating artery, the communicating segment, and the terminal branches, which are probably the most important. I mean, every single one of these is important for whatever reason, but the posterior communicating, which is a part of the circle of Willis, and then distal to that, the anterior choroidal artery, which I'll talk about shortly, and then the terminal branches, the anterior cerebral artery and the middle cerebral artery. It's a lot of information, so I apologize, but it's important to understand that aspect. How's that going? Next slide. Right. This is an angiogram which shows the same thing essentially, and there are a few characteristic features on angiograms that will help you orientate to what you're looking at. You can see this is a lateral projection. You can see the carotid siphon here that I was talking about, and one of the most, to me, obvious branches is the main branch that juts out directly anteriorly from the carotid siphon, and the position of this can be variable as well, but there is your ophthalmic artery, and that is a lateral projection. An AP projection looks AP, but an AP angiogram is a lot more obvious because you can clearly see the medial anterior cerebral arteries and the lateral middle cerebral arteries. There are several different ways of classifying the ICA. The one I've been through is the Cincinnati system from 1996. The reason I use that is because it's the one that's classically used in books. Al Roton is a famous neurosurgeon and anatomist who sadly died a few years ago, who simplified this version. And Amin Kassam introduced a newer way of splitting the ICA based on the fact that through an endoscopic endonasal approach to the ventral skull base, you need to think of the carotid slightly differently, and I'll show you some pictures of that. This is looking basically just underneath the frontal lobes towards the back of the head where the basilar artery sits in front of the brainstem. The infundibulum of the pituitary has been cut here, and you can see either side the ICAs. There are a number of perforating arteries that are very important, so you can imagine if you're trying to operate and retracting the frontal lobes upwards, you need to be careful of tearing these vessels. The very first branch that you can see coming off the ICA is the ophthalmic artery, and you can see the branch here, which is the green one, the anterior choroidal artery, which is going backwards and traveling along the optic tract. That's quite important. And then you've got the final bifurcation of the MCA and the ACA here. These are some endonasal endoscopic views. So the picture on the left is basically inside the sphenoid sinus. I don't know if you can see my arrow here, but you can see the internal carotid artery on the left and on the right. This is the midline, and this is looking up the nose into where the pituitary gland would sit. And you've got the internal carotid arteries either side here, and sometimes the bone is that thin and sometimes there is no bone at all. So when operating in this area, a carotid injury is a very real risk, as it happens about 1 in 200 cases and can be extremely terrifying if you're the one doing it. Here you can see we've removed the bone, and you can start to see the sinuses that go around the pituitary, and here you can see the optic nerves from the chiasm. Again, I go back to the point of understanding arterial anatomy and relating it to the cranial nerves. You will, as you repeat your anatomy, and I'm sorry, but the only way is with repetition. The more you repeat your anatomical studies and your revision, you will start to see the relationships more clearly. Again, this is a slightly higher view, so this is if we sort of look a bit more upwards, and these are the inferior aspects of the frontal lobes, which you can also get through endoscopic, extended endoscopic approaches. And here you can see the olfactory nerves. You follow these back, and it takes you to the optic nerves, which you can see here, and there you can see the infundibulum, and there's the pituitary, and here are the ICAs again. This is just to demonstrate how close everything is. It can be easy to think that the anterior circulation and the posterior circulation are miles apart. Remember, the posterior circulation, the main trunk of the posterior circulation, the basilar artery, lies in front of the brainstem. There isn't a huge distance between these, and really the only thing that's been removed here is the clivus with the associated ligaments behind it, and obviously the dura. But you can see the basilar artery here. It's not a million miles away, but there is an important bone that we have removed to kind of demonstrate that point. Again, you can see the optic nerves up here. A little bit about the anterior choroidal artery, because it's an artery that, to be honest, I had never heard of as a medical student, but it packs quite a punch. It's one of the smaller terminal ICA arteries, but if you take it, it can, because as you saw earlier, it travels with the optic tract, it can cause homonymous heminopia, but it then also supplies parts of the internal capsule leading to hemiplegia and hemisensory loss. So taking this can cause quite a problem. It's identified on an angiogram as being the smaller artery that comes off the ICA distal to the posterior communicating artery. The posterior communicating artery should be more obvious, and the anterior choroidal artery has a cisternal segment that goes up and then a plexal point, and that's where it enters the choroid plexus. There are many choroidal arteries, and the clue is in the name. They supply the choroid plexus. So there's the anterior, and then there are several posterior and lateral, posterior lateral choroidal arteries. Anterior cerebral artery anatomy, you have to remember two things. One is that it supplies the medial surface of the brain, and number two, it's entirely related to the corpus callosum, and that's how you get its breakdown of its different segments. All the arteries are basically split into 4 or 5 segments, apart from the ICA. The first part of the anterior cerebral artery, A1, is from the bifurcation to the ACOM, the anterior communicating. Remember, the anterior communicating is that anterior part of the ring road of the Circle of Willis. Again, huge amounts of variation. You've then got A2, which is posterior communicating, up until the point that you reach here, where you get the pericallosal. In between the pericallosal and the in between the pericallosal and the callosum marginal, you've got the cingulate gyrus. So again, the arteries provide a road map to where cerebral cortical structures are as well. So you've got posterior communicating, then you've got the precallosal section, and then the supracallosal section, and then the postcallosal section. I'm not going to go into the details of all of the separate branches, but know that it basically goes in order of the frontal pole, medial frontal, and then medial parietal, with branches going specifically to the central sulcus or the Rolandic fissure, and the pre and post central gyrus. So that supplies the medial aspect. Clinically, that's important because an occlusion here will take out the motor power or the sensation from the waist down, because if you remember your homunculus, and if you don't, I'm sure one of my colleagues will teach it in one of the later lectures. Another artery that is small but packs a punch is the recurrent artery of Hübner. Not as big a punch as the anterior choroidal, but it's important because it's the largest of these group of arteries, which comes off of the anterior cerebral artery, and they're the medial lenticular striate artery. So the largest of the medial lenticular striate arteries is the recurrent artery of Hübner, which supplies the head of the caudate and the base of the frontal lobes. So again, you take this out when you're trying to clip an ACOM aneurysm, for example, is the classic thing. If you accidentally take this, you'll end up with a caudate infarct with personality changes, abulia, and face and arm sensory loss. The middle cerebral artery is the largest branch, the term of the two main arteries. It is a huge artery, and it supplies a huge amount of the lateral side of the cortex. Again, the labeling varies slightly, but M1 is the first section, which is from the bifurcation, from where it comes off of the internal carotid to the bifurcation. Usually there is variation, sometimes it trifurcates in 12%, and that's where it becomes the insular portion. As you get out to the outer aspect of the brain, so where it finally makes it to the cortex, is the opercular segment. Opercular basically means curtain, and again, when you're covering cortical anatomy, this area is quite important to understand. But the MCA comes out through there and provides branches to the frontal, temporal, and parietal lobes. And there are a large number which again almost go gyrus by gyrus. On the superior branch, and the inferior branch supplies the temporal, lateral temporal surface. Right, we'll move on to the posterior circulation. The vertebral artery is comes off of the subclavian artery, and this is the these are the main branches that join to form the basilar artery. There are 4 segments. It's actually quite easy to remember the segments of the vertebral artery because it doesn't have a huge number of branches. So from the V1 segment is from the subclavian to where it enters the transverse foramen of the C6 vertebra. That's quite important to remember. It's not the C7, it's the C6. The C7 has a foramen, but it doesn't go in through there, usually. Obviously, there are always anomalies. V2 is the straight segment that goes through all of the transverse foramen until you get to V2. Again, V1, it does travel around V1, but the V2 segment stops at C2. The V3 segment then comes out of C2, travels laterally, then vertically, and then enters C1 through its transverse foramen. So it does have a transverse foramen, but it's not part of V2, it's part of V3. And then where it enters the dura, it becomes V4. The most important branch of the vertebral artery is the posterior inferior cerebellar artery, the pica. Remember, this comes off the vertebral. And again, once you start to appreciate, so I'm going to jump ahead a little bit here and talk just briefly about pica, ICA, and SCA. So SCA is superior cerebellar, ICA is anterior inferior cerebellar, and pica is posterior inferior cerebellar. 3 main arteries of the posterior circulation, each one intimately associated with cranial nerves. Pica is associated with the lower cranial nerves. The vertebral actually runs past 12. Pica then runs between 10 and 11. ICA provides branches to the 7th and 8th cranial nerves and provides the labyrinthine artery. This is important with hemifacial spasm. It's also the labyrinthine artery in vestibular schwannomas or in any pathology causing compression. If you get sudden loss of hearing, that's a labyrinthine artery infarct, which is a branch of the ICA. The superior cerebellar artery, the third cranial nerve, although you can't see it in this diagram, runs very close to the SCA, and the third cranial nerve, remember, continues anteriorly and is very close to the posterior communicating artery. So the posterior communicating artery is, when you've got aneurysms there, that's the one that compresses your third nerve. Also, in brainstem herniation syndromes, if you've got massive swelling, it's the posterior cerebral arteries and the PCOMs that are compressed as the brain shifts down and presses these vessels against the tent. With trigeminal neuralgia, if you've got a neurovascular conflict, that's usually because of an SCA loop causing a neurovascular conflict with the fifth cranial nerve. Anyway, I'll go quickly back to pica. Again, 5 segments, and all associated this time, instead of the corpus callosum as with the ACA, it's the medulla. You've got the anterior medullary, the lateral medullary, the tonsillomedullary, so your cerebellar tonsils are down here, and the pica loops around those, and then it goes a bit more medial, the telovelar tonsillar, and then hemispheric branches. An infarct of these segments will cause lateral medullary syndrome, which is Wallenberg syndrome, which is the kind of thing that would come up I think would come up in some examinations, even at medical school. Important about the pica, you've got 2 loops. You've got a caudal loop and you've got a cranial loop. This cranial loop has quite good concordance with where the choroid plexus is of the 4th ventricle, which is behind here. So again, providing a roadmap to your brain. This is basically just a slightly better picture showing its relationship with the lower cranial nerves, the caudal loop, the cranial loop. This is the 4th ventricle, and then it sort of dives inwards. The basilar artery is unmissable. It's the largest artery of the posterior circulation, and one thing to remember is that your posterior circulation does develop slightly later on in fetal development, so it isn't always as well developed as the anterior circulation, and I'll talk about that in a little while. But if you divide it into the lower third where the ICA comes off, remember the pica has already come off the vertebral at this point. Then you've got pontine perforating arteries. These are the ones that you never ever want to touch or see a lot of the time. And then the distal third where your superior cerebellar artery comes off of. So I've mentioned the ICA already. Again, there are 4 segments, and it's now more linked to the internal acoustic meatus. So you've got this pre-meatal pontine section, lateral meatal pontine section. That's where your labyrinthine artery comes off of. And then the flocculus, which is an anatomical landmark next to the 7th and 8th cranial nerves. And then again, you've got cortical branches supplying the medial ventral part of the cerebellar hemispheres. Finally, your superior cerebellar artery, again, 4 branches. I'll go into this in a bit with the CSF section, but all major arteries travel through CSF. And I'll go into this in a bit more detail, but essentially the main arteries travel through the cisterns, and then as they get more and more cortical and more into the brain, they are still traveling through smaller and smaller subarachnoid spaces. And you can see that with the superior cerebellar artery, because this is a sort of cistern city around the midbrain. So you've got the anterior pontine, the ambient section, which travels in the ambient cistern, again runs with cranial nerve 4 right next to the free edge of the tent. The quadrigeminal cistern, which also houses a section of the posterior cerebral artery, and then you've got your cortical branches, which supplies the superior surface of the cerebellar hemispheres, and actually anastomose with each other. So the SCA and the pica anastomose to provide full coverage. We finally get to the end of the basilar artery, and then it divides into the two posterior cerebral arteries. Again, you have to think about this. If this is the posterior side of the brain, this is the basilar artery, and this is the brainstem. The PCA travels around the brainstem, supplying blood to the lateral aspect of the brainstem, but also has numerous branches going to the thalamus, the choroid plexus again. So you've got your posterior arteries. It supplies the posterior temporal lobe. It has a hippocampal artery branch, and these are all coming off of the P2 and P3 segments. So again, posterior goes from its origin to where PCOM joins, and then from where the PCOM joins to the posterior midbrain, you've got the mesencephalic sulcus, and that's what divides P2 to P3, and then P3 travels in the quadrigeminal up until it reaches the free edge of the tent, and then goes up to provide the calcarine and the parieto-occipital arteries. These are the arteries that in brainstem herniation, in brain herniation syndromes, if you are going to get compression anywhere, it's going to be at that segment there, and you'll get a large infarct of the posterior part of the brain, which goes to your occipital lobe, which gives you visual deficits. This again is another depiction of the posterior cerebral artery, more in a sagittal projection, and what you can see here on a sagittal angiogram. Again, the picture of a lateral posterior circulation injection on an angiogram is quite characteristic, and it's quite good to familiarize yourself with these now. You compare this to what the ICA looked like with the carotid siphon. They are two very different arteries with very different pictures. Again, it's the kind of thing that you just kind of have to keep looking at again and again. Here you can see the vertebral artery, you can see the pica here, and you can almost make out where the tentorium would be and where the cerebellum fits in this space. I don't know if I'm just saying that out of years of convincing myself, but if you understand the anatomy, it starts to become clearer. You start to see structure through these angiograms. Okay. There are many vascular abnormalities. I'm not going to go through all of these in the interest of time, but the main ones which I want to talk about are the persistent, or what's called a fetal posterior communicating anomaly, or fetal PCOM. A fetal PCOM is when your PCOM is basically larger than your P1, which means blood supply is going from anterior to posterior via the PCOM at a rate that is a bit unusual, and that's because of underdevelopment of the posterior circulation. So usually with these anomalies, you have a puny basilar artery, and you have sort of more bulky anastomotic arteries. PCOM is the most common, and indeed it exists as part of the circle of Willis. The next most common, which is quite rare, sort of, I think about 1 less than 1%, will have what's called a persistent trigeminal artery. The rest of these are rare as hen's teeth. Hypoglossal, proatlantal, as well as otic arteries, which they haven't even bothered to mention here because they're so bloody rare. And then here you've got your vertebral, and here you've got your ICA, anterior circulation, posterior circulation. This again shows what I was referring to with regards to the PCOM. You end up with a smaller posterior cerebral artery. A smaller posterior cerebral artery and a much larger PCOM supplying the blood supply on that side. Blood can shunt from posterior to anterior, anterior to posterior, and from left to right. That is the purpose of the circle of Willis. Again, persistent trigeminal, very rare, but if you do have one, you end up with an underdeveloped posterior circulation. To go back full circle to the external carotid artery, the external carotid artery anastomoses with the internal carotid artery at multiple points. I would ignore this posterior cerebral bit. There is anastomosis with the occipital artery, but that's not directly with the posterior cerebral artery. It's more with the posterior meningeal arteries. But importantly, that superficial temporal artery, which you can feel on the side of your head, and the internal maxillary artery, which provides the middle meningeal artery, that's the one that classically ruptures with skull fractures, giving you an extradural. This is an extradural vessel, can anastomose with the internal circulation. Similarly, the facial artery that we saw earlier on that very abnormal looking scan, anastomoses via the angular artery and the supraorbital artery to the ophthalmic artery, and that is an important anastomotic connection. They use this, in fact, to deliver direct chemotherapy to retinoblastomas by supplying it directly into the ophthalmic artery. But it's important to understand that there are collaterals, and yeah, that's just an important feature. I'm just trying to switch slides. Thalamus has a blood supply that comes from many different arteries. One thing to mention is that there is an important anatomical variant from P1, from the posterior cerebral artery. You can have a single, something called artery of Percheron, which can supply both thalami, and so one vessel will cause a bithalamic infarct. That's an unusual variant, but something that, again, every once in a while comes up in conversation. You can see that the medial striate and the lenticular striate arteries, that are those small, unnamed groups of arteries, supply a large amount of the basal ganglia and the thalamus. That's why they're so important. Yeah. So that's all I'm going to talk about with regards to arterial supply. I appreciate that that's quite a lot of information, but that is the bulk of neurovascular anatomy because that's where it's most consistent. The venous anatomy varies somewhat, but I will go over that in just a moment. Does anyone want to ask any questions at this point, or shall I continue? Are you all still alive?
Still alive, all good.
Good, okay, right, excellent. Good. Important part of neurosurgery is, unfortunately, stamina. Right, okay, so I'm going to move on to CSF circulation. Now, the classic teaching with regards to CSF circulation is that your choroid plexus produces it, it circulates around your ventricles, goes into the cisterns, goes around your spine, and then all gets magically reabsorbed in the arachnoid villi into your venous system. It does this at a rate of 500 mils a day. So if you think you've got about 150 mils of CSF inside your central nervous system, and you produce 500 mils a day, so it's got quite a fast turnover. And to think of CSF as just a shock absorber, it's simply not. There's a lot more to it than that, which is well beyond the scope of what I'm going to be able to cover today, but it's important to understand. So in terms of the anatomy, I'll go through the ventricular systems first. So number one, it's important to remember that you have choroid plexus in your lateral ventricles, in your third ventricle, and in your fourth ventricle. It doesn't just all start in the lateral ventricle and make its way around. With every time your heart beats, all of the arteries in your brain, and you saw how many there were, pulsate, so they expand, and this is absorbed with every pulsation through the CSF. So when you operate on the brain and you see CSF, you see it pulsates, and it has a very specific waveform as well. Anyway, you have two lateral ventricles. The lateral ventricles are split into the anterior horn, the body, the posterior horn. You've then got the atrium, the occipital horn, and the temporal horn. They're forming this C shape, and you have two of those lateral ventricles. They then connect to the third ventricle through the foramen of Monro. The third ventricle is a midline ventricle. You only have one. It's in between the two thalamic hemispheres. You may be able to see this gap. That's because there's brain in that gap, and that's the interthalamic adhesion, or the massa intermedia. And that's either side of the third ventricle, and the thalamus imprints on either side of the third ventricle. The third ventricle also is the CSF space above the optic chiasm. Posteriorly, you've got the pineal gland, you've got the hypothalamus, and the thalami either side. Again, the ventricular system is a good way of giving you an impression of the surrounding brain structures. So the roof of the lateral ventricles is the corpus callosum. The medial wall of the lateral ventricles is the septum pellucidum. At the base of this, the ceiling of the third ventricle, are your fornices as they come round and then form the mammillary bodies just posterior to the third ventricle. You then have the cerebral aqueduct connecting the third ventricle to the fourth ventricle here, and you've got outlets laterally, which are the foramen of Luschka. Easy way to remember that is L Luschka, L lateral, and the medial foramen of Magendie. M for medial, M for Magendie. That, in a nutshell, is the ventricular CSF flow. Now, around the brain stem, you've got basal cisterns. And as I was saying, the cisterns are where you're going to find the major arteries. All proper neurosurgery, as one of my bosses once told me, involves arachnoid dissection. Now, it's important to understand the arachnoid is not a single film layer. It is a web, as you were told in the last teaching session. It derives its name from spider web, from arachnoid. And it is a web of thin connective tissue, and it's through this that your blood vessels course through. So all of the stuff I've talked about, they're all traveling through cisterns. Now, the main ones that I'm going to cover are the suprasellar cistern, which is the space above your cellar, which is where your pituitary gland sits. It's where you find the infundibulum. It's where laterally you will find the internal carotid arteries. in the suprasellar cistern is where you're going to find the optic chiasm, and it's where you're going to find the anterior cerebral arteries as well. As you go further back, so this, by the way, is an AP view here. Sorry, is a transverse view. So this is looking the front of the head is here, the back of the head is here. This here is the brainstem. Can everyone hear me okay? I'm just getting warnings about poor call quality.
Yeah, we can still hear you. It cut out for a couple of seconds, but it's good now.
Fine. Okay, good. So there's your suprasellar cistern here. Your prepontine cistern, as the name suggests, is in front of your pons. That is where you will find the bifurcation of the basilar artery into the posterior cerebral arteries. Ambient cisterns are the ones that go around the side. You'll see here the ambient cistern is actually this bit. The crural cistern, which this doesn't show, is the connection. So crura is from knee, it connects the prepontine or the interpeduncular cistern round to the ambient cistern, which then connects at the back to the quadrigeminal cistern. Again, this is where you're going to find your SCAs. This is where you're going to find your quadrigeminal segment of the posterior cerebral artery, which you can see coming around here. You've got your Sylvian fissures here, or your Sylvian cistern. That's where you will find the middle cerebral artery. And you've got the interhemispheric cistern, or interhemispheric space, which at the very bottom is where you're going to find your anterior cerebral arteries. There isn't actually much more to say about that. Before I go on to venous anatomy, does anyone have any questions about that? Okay, I'm going to carry on. Right, venous anatomy. So at the beginning, I said I would go through the superficial and deep venous drainage. Now, the first thing to say is that the venous system, especially superficially, has a lot of variation. There are constants, with the exception of in pathology, which I'm not going to go into, but the main, most recognizable sinus or draining vein is the superficial sagittal sinus. This is a collection of draining veins forming in the midline at the top of the falx, within a sinus within the dura, and actually is made up of small venous channels that all kind of coalesce together. As you go from anterior to posterior, it gets bigger because it's draining more blood. Anteriorly, the draining veins connect almost perpendicular. As you get further back, they start to run in parallel with the sinus. That's almost entirely constant. At the back, it then forms the confluence of sinuses where the two transverse sinuses join. Occasionally you have a occipital sinus, which is usually more predominant in children, but the main drainage from the superior sagittal sinus through the transverse sinuses, and then through the sigmoid sinus and the internal jugular vein, and out to the neck and to the heart. Here you'll see a Mercedes-Benz sign. Now, the reason I've picked this is because these are the three main anastomotic veins of the cortex. And there are three. This varies from person to person. One may be more dominant than another, and when it is, the other two can be slightly smaller, but they have specific names. This is the middle cerebral vein, or the middle or the superficial cerebral vein, sorry, and then you've got the anastomotic vein of Trollard, and that's Trollard, and the anastomotic vein of Labbé. Now, the way to remember them is Trollard goes to the top, which is TT, which goes to the superior sagittal sinus. Labbé drains lower to the transverse sinus. As I said, sometimes this is almost non-existent and this is bigger, but the veins are extremely important. And you take one of these veins and it's draining a large area of brain, it will result in very abnormal looking venous infarcts and bleeds, and they can be extremely damaging. I'm happy to talk about that a bit more later on, but that's the kind of the cortical venous system. You'll start to see clues of the deep venous system here. Underneath, you've got the inferior petrosal sinus and the superior petrosal sinuses, which are coming from the cavernous sinus, and I will talk about the cavernous sinus in just a moment. When you take away the brain, this is quite a nice diagram showing you more of the venous drainage. So here again, your superior sagittal sinus. Lower down, you've got an inferior sagittal sinus. This marks the bottom of the falx. So between here and here, you've got the falx cerebri. The other thing to talk about with the superior sagittal sinus is it's split into thirds. The anterior third is relatively safe to take without causing huge amounts of swelling and problems. If you end up with something compressing the middle and particularly the posterior thirds, then the amount of backup flow is larger and the amount of swelling will be worse. Between the inferior sagittal sinus and the torcular, you've got the straight sinus here. The straight sinus connects to this confluence of veins, and then it's, as we mentioned previously, with the transverse sinuses. I'm going to talk a little bit more about now the deep venous drainage. Inside your ventricles, your lateral ventricles, you've got septal veins, you've got thalamostriate veins, draining very deep and very important structures. They travel with the choroid plexus into the foramen of Monro. If you remember, that's between the lateral and the third ventricle. And they then turn that corner and travel as internal cerebral veins at the roof of the third ventricle. You can imagine an infarct or a problem with either of these veins can cause fairly significant damage given the structures in this area that are being drained. The internal cerebral veins then join into a great cerebral vein where they're joined bilaterally basal veins of Rosenthal. The basal veins of Rosenthal are also important deep cerebral veins that are draining the medial temporal lobes, but also drain from the cavernous sinuses. And again, they will drain out through into the straight sinus, the great cerebral vein is also known as the vein of Galen. In very young children, there can be venous anomalies of this vein, which can be so bad that it overwhelms the circulation of the child and they present in hemodynamic failure very early in life. Again, this is getting sort of beyond the remit of what I wanted to talk to you about, so I'll move on. And here you can see the superficial middle cerebral vein, and there's Labbé and there's Trollard. So you can see that's what we could see in the earlier picture up here. That's the majority of the deep venous drainage system, and I think if you could remember all of that, that would be exceptional. But the cavernous sinuses are another structure within their own right. They're anatomically very important, and again, the structures around the cavernous sinus and within the cavernous sinus are anatomically very important. Within this very small space either side of the pituitary gland, you've got the internal carotids in the cavernous segment, which we covered earlier. You've also got the sixth cranial nerve, the abducens nerve, which is the only cranial nerve traveling within the actual cavernous sinus itself. The rest are plastered to the lateral wall of the cavernous sinus, and they include the third, the fourth, and the first two branches of the fifth, the ophthalmic and maxillary. But this remains a venous sinus. It's connected through multiple draining veins. The petrosal veins that I mentioned draining outwards. You also get cavernous sinus drainage from the ophthalmic veins. And the reason this is relevant is that if you crack your head open and you get a traumatic fistula between the carotid and the cavernous sinus, your orbital veins will massively dilate up because you've got arterial flow causing back pressure through those ophthalmic veins, and you get a big red eye. It's pretty much diagnostic, and it's the only time as a neurosurgeon you might need to put a stethoscope on someone's eye to listen for a bruit. But again, another important venous conduit between the deep and superficial circulation. Here just basically is what I was talking about in terms of the main tributaries. So you've got a cavernous sinus either side, you've got drainage from the brain, from the meninges, and from the eye. There is communication, as I said, with the external circulation, and then you've got superior and inferior petrosal sinuses draining the cavernous sinus into those bigger veins, the transverse and sigmoid, as I mentioned earlier. And then you've also got veins that drain down in through the foramen magnum. Right, I think I've just about managed to stick to time. I want to thank you for bearing with me if you're still awake and alive. There is a huge amount of information, as I said, and I've tried to go over the main points, and probably I would suggest probably beyond everything that you need to know at medical school level, but if you know that, that's a great start. This is the QR code to leave any feedback if you wish. I should probably now hand over to the excellent organisers who invited me to give the talk. Thank you.
Thank you, Mr. Matloob. And I'd like to ask all attendees to fill out the feedback and place your names so as to take attendance. It was very comprehensive, and I think we're all still alive and awake. So thank you very much. If anyone has any questions, feel free to either put them in the chat or unmute yourself and ask them.
Stunned into silence, hopefully.
You kind of touched on it, but how common is vertebrobasilar insufficiency in cases that you see?
So I don't see that much of it, to be completely honest with you. The majority of things that you see from a neurosurgical perspective are posterior circulation aneurysms or abnormalities associated with the vessels. In terms of insufficiency, it actually isn't that common. if you think about it in terms of how often do you see fetal PCOMs and trigeminal and any of those other weird anastomotic abnormalities, we're talking, I'm guessing, in the region of no more than 5 to 10%. In terms of eponymous syndrome, you just reminded me of something called Bow-Hunter syndrome, which is because of compression at the level of the vertebral artery. You can get patients who develop neurology every time they turn their neck. Again, very rare, but it's the kind of thing that sticks in your head. Questions. Sorry?
Thank you.
Any other questions, guys?
I just wondered if, Mr. Matloob, if you could recommend any good resources for some additional self-directed study on, particularly on neurovascular?
Yeah, absolutely. The authority on neurovascular is Rhannon. You can access, if you search online, there is a library of Rhannon's images. There is a book, a NeuroAnatomy book, which focuses mainly on cerebral anatomy, but in particular neurovascular, and that's definitely an excellent resource. It does just come also with repetition, with looking again and again at angiograms in particular, because that's the best way to see the anatomy, the neurovascular anatomy. And you can Radiopedia actually is, I do think, is quite a good source of images that talk quite nicely through the images that you can see, and starting off with normal anatomy to begin with is what I would recommend, and then as pattern recognition gets better, you start to notice differences and abnormalities, but those are the two things I would recommend.
That's great, thank you very much.
Great. Well, if there are no other questions, or I'll leave it to you guys to moderate.
Thank you. So I don't think there are any more questions. I can't see any. If anyone would like to ask a question, feel free to unmute. Mr. Matloob's a nice guy, don't worry.
I can't actually see the chat, but
yeah, I don't think as a presenter you can see the chat.
oh, fine.
We have a problem with our chat function where only people who are part of Imperial can post in it for some reason.
Oh, okay.
We've tried to modify that, but we'll try to figure something out.
I'll stop all the gate crashes.
Mm.
I was a Barts student, by the way, so
Nice.